Uh, we're going to begin the afternoon session, and I want to welcome again participants that are joining us via the webcast. We're going to begin this afternoon with discussions with the Bronx Transition Clinic and Transitions Clinic Network, and I would like to introduce for this Dr. Aaron Fox from the Bronx Transition Clinics in New York, and Dr. Shira Shavit from the Transitions Clinics Network. Dr. Fox, Associate Professor of Medicine at Albert Einstein College of Medicine and Montefiore Medical Center. He's a primary care physician with board certification in addiction medicine and training in clinical research methods. Dr. Fox is a co-director of the Bronx Transitions Clinic, or BTC, which provides a medical home for individuals who have recently been released from jail or prison. Dr. Fox is working to develop behavioral interventions to complement pharmacotherapy for opioid use disorder, improve linkage to care following release from incarceration. Dr. Shavit is a clinical professor of family medicine at the University of California, San Francisco, and the executive director of the Transitions Clinic Network. For over a decade, she has been redefining national best practices for the care of individuals and communities impacted by incarcerations. The TNC is a national network of community health centers which specialize in providing patient-centered care for people with chronic health conditions who are returning from incarcerations. To support their goal, the TCN trains and employs people with a history of incarceration or community health workers, creating opportunities for people with a history of incarceration to leverage their experience toward a career in the health setting. Aaron and Shira, thank you for joining us. Can you each provide us a brief introduction to your philosophy and model of care, perhaps starting, Aaron, you, and then we can prioritize and open discussions and go from there. And again, open up to the committee for questions, and we will go do this until about 2 o'clock when we will have to end to go to the next program. So take it from there.
Okay. Shira and I had spoken a little bit. Is it okay if Shira presents first?
Sure. Shira, are you ready? Can't hear you. Are you muted? Yeah, can you unmute? Okay, it's better. Can you raise your volume?
Yeah, can you hear me?
That's way better.
Okay, great. Yeah, it helps when you unmute the phone. So, hi, can you guys see me? Yes. Okay, perfect, great. So I'm Shira Shavit. I'm a family physician, and I'm the executive director of the Transitions Clinic Network. As you heard just a little bit, the Transitions Clinic Network is a national nonprofit that provides technical assistance and training to health systems to better care for people with chronic conditions returning from incarceration. We have worked with over 30 health systems in 12 states and Puerto Rico, and we work with these sites to implement a model of care that we developed here in San Francisco in 2006. And then, we call that program the Transitions Clinic Program. It was initially developed by my colleagues Emily Wong and Clemens Hong in conjunction with community organizations here in San Francisco, both City College of San Francisco, which trains community health workers, and with All of Us or None, which is an advocacy organization that supports families and communities impacted by the criminal justice system. And so this program was initially started kind of in response to seeing that our systems in San Francisco weren't meeting the needs of people coming home, and we did a series of focus groups with our partners and heard from the patients that we serve and the communities that we serve that primary care as it stands wasn't really meeting the needs of people coming home from incarceration. And we learned that we needed to transform what we do at the primary care system in many ways to be better serving those communities. So some of the things we learned from those focus groups was that we needed to broaden our definition of health and well-being, not just focusing on physical care, but also on integration of behavioral health services and all the social determinants of health. We also learned that people coming home from incarceration really wanted to be integrated into the existing community services and didn't want services that were separate because they had this history of incarceration. So for instance, putting a clinic at probation or parole really kind of separates people from the community. They wanted to be integrated within their communities. The communities also said that it was really important to not replicate the criminal justice system, so to ensure that all of our programs weren't inadvertently becoming the arm of the criminal justice system, and that they were really kind of primary care clinics where people could feel that they had privacy and confidentiality, and that kind of punitive system wasn't inadvertently being replicated. And then lastly, and probably most importantly, what they said was that people who were impacted by the criminal justice system really needed to be involved in both the design, implementation, and evaluation of programs serving their own communities. And so with this, we developed the Transitions Clinic model of care. It's a model of care that's embedded within existing primary care systems. So we're not creating separate clinics. We're providing enhanced services and leveraging existing primary care resources. Most of our clinics are based in federally qualified health centers, community health centers, and the model of care employs and embeds community health workers who have histories of incarceration as part of the primary care team. The program also transforms what they do at the primary care level to make sure they're meeting the needs of patients, so really looking at a system level, making sure that the clinic is well integrated with the criminal justice system, as well as with all of the social determinants of health in the community that's needed to support patients. And then also really looking internally at existing policies and procedures to see how they impact patients. So a really good example of this is the 15-minute late policy. Most primary care clinics have a 15-minute late policy. If you show up 15 minutes late for your visit, you don't get seen and you have to reschedule. Well, if you have someone coming home from incarceration who doesn't know how to navigate the system, it might be very difficult for them to get to the clinic. They maybe got lost because they don't know their way around or can't use technology. It's very frustrating for these individuals to show up and then turned away. And what we heard also from our partners is that people really mistrust the health system in the same way they mistrust the criminal justice system. So getting turned away feels very punitive and people may not want to come back. So that's just one very small example of how our programs really try to address kind of system change. And so when we think about our work, we really think about transforming the primary care system. It's not just employing and embedding the community health worker, but you have to change the entire structure of what you're doing in primary care to best support the community health worker and then also have better integration with broader systems to really meet the needs of the clients that you're serving. So as I mentioned, this is a program that we've implemented in 30 states in Puerto Rico. Our organization does technical assistance and training, and we work with interested health systems to implement this model. And we start, really with kind of an assessment of whether the health system has kind of the components that are needed to be successful. We were able to evaluate our work and kind of get a better sense of what are the components of primary care clinics that make this work successful. And then we work with the systems in that transformation, both in the implementation and provision of services, as well as really helping the primary care clinics kind of break down their walls and expand their services to have better integration with the primary care services in their community. We work with the systems to hire and train the community health workers. Hiring individuals with felony convictions in the community setting or in the health setting can sometimes be challenging, and so we work with sites in that piece. We also train the community health workers, not in the core competencies to become community health workers, but in the more specialized services they need in better caring for individuals who are coming home from incarceration. And so really kind of in the implementation of our model. And then we also do training with the clinics, both for the implementation of the work as well as kind of cultural humility training and supporting the training of the staff so that the program is well supported throughout the clinic. So that's kind of our program overall. I think maybe I'll keep it brief and then we can let Aaron talk maybe a little bit more specifically of what that looks like in the Bronx, and then happy to answer more questions about our evaluation, kind of maybe more around sustainability is kind of how our programs have been able to do this work.
That's excellent. Thank you.
Yeah, sure. So I think, so building off of that model, we started a transitions clinic in 2009 after reaching out to Shira and the others at San Francisco, to try to learn about what they were doing. And I think the two things that make our site unique, one is our relationship with a community-based organization called the Osborne Association, who make a lot of the referrals. We're really intimately involved with the Osborne Association, and they provide the community health worker. They train the community health worker, and the supervision is through the Osborne Association. And the other thing is really the comprehensive services that are available at our FQHC. It's a residency training site. So we have a primary focus on training residents. Most of the providers within the FQHC are internal medicine medical residents in the primary care and social medicine residency program at Montefiore. So I think that's a really important part of what we're doing, because we're training the next generation of providers, both in these skills in treating HIV and treating opioid use disorder and treating hepatitis C, but also providing care to people with criminal justice involvement, and then also their families as well. And this is kind of a tangent here, but I think that's probably one of our biggest successes, is providing mentorship to these training residents. And in 2009, our clinic actually stemmed from a residency project. One of the social medicine residents, Ross McDonald, was interested in implementing this program within our FQHC. So he did a lot of the groundwork. And since then, he went and worked at Rikers. He was the assistant medical director and then the medical director, and now he's the chief medical officer in correctional health services within the Health and Hospitals Corporation in New York City. And since then, we've had residents, right now at Rikers Island, the main jail in New York City. The medical director is one of our graduates. The director of the opioid treatment program at Rikers is one of our former chief residents. The director of the medical education program at Rikers, James Gregg, is also one of our graduating residents. So I think creating this culture of this is bread and butter medicine for primary care. You need to know HIV, you need to know treatment of opioid use disorder using buprenorphine, you need to know best practices for people with criminal justice involvement, and having this be a successful, a legitimate career path for people, I think has been one of our biggest successes. But so going back to the model, the Osborne Association has staff members within New York State prisons and then also within the jails. So they have multiple different programs that they offer to people with criminal justice involvement and their families. I mean, they offer outpatient substance use disorder treatment. They offer family programs, job readiness programs, other social services. So they have a separate site that's off-site from the FQHC. They have staff members upstate in the prisons, and then they also have staff members at the local jail. Our particular community health worker does the difficult work of engaging people prior to release, engaging people when they're at the Osborne Association, and then doing the patient navigation to help people make it to the transitions clinic. And the way that I conceptualize things, that in this reentry process, when people are coming home from jail or prison, there's the process of pre-release discharge planning. There's the process of linkage to care. There's the process of engagement once people come into care. And then there needs to be a focus on retention in care. And I think in the literature and a lot of the things that we're hearing about in the community, it's really focused on that linkage. Well, two things. It's focused on getting people Medicaid at the time of release and then focused on that linkage. And I think what we're trying to do with the transitions clinic is also think about that engagement. So like Shira said, when people come into the community health center, what's that experience that they have in seeking care? Does it reinforce some of the experiences that they had in the criminal justice system? And the way that I think, we've talked about stigma a lot already during the day. So building off of the HIV stigma literature, we're thinking about the different types of stigma that there might be, like anticipated stigma, perceived or experienced stigma, and internalized stigma. Well, we can apply that to criminal justice involvement as well. So if someone has anticipated stigma, they think they're going to go see the doctor and they're going to be treated differently because they have criminal justice involvement. And when you think about this, the doctors within jail or prison, a lot of times they're doing assessments before people are going into solitary confinement. So they're part of the criminal justice system. And that has an impact on people. Patients will tell us that, some doctors are good, some doctors are just part of the system. So if someone has that anticipated stigma, they think they're going to be treated differently. They get to the clinic, the staff is overwhelmed, And then as soon as they walk in the door, the staff tells them, well, your Medicaid's not active. You need to go downstairs and see the Medicaid enroller. Someone's rude to them. Then that type of stigma can tell them, well, I'm just not coming back. Or when it comes to someone seeking medical care, I think one of my really telling experiences earlier in my career is seeing a patient who's HIV positive, had a history of substance use disorder, not with opioids, but was going to see a pain doctor and getting chronic opioid therapy for a pain condition, and then asked me for pain medicine. And I tried to set limits. This is in a respectful way, but a firm way. That I don't, you have your one pain doctor, you should be one doctor prescribing opioids, and really being firm and rigid about it. But I guess in my tone, just the way that I was talking to her, we had a close enough relationship where she was able to at least tell me, Dr. Fox, you sound like my parole officer. And I was really taken aback by it. I said, I'm sorry. I would never want to make you feel that way. So I think in terms of the cultural humility or the cultural competence of the providers, thinking through these things. So if someone's coming in with opioid use disorder, the way that we ask them to provide a urine drug test, does that reinforce the experience that they have when they go to parole? I mean, some of these things, that you don't learn about in medical school are really important. That's part of the cultural humility, I think, that the residents learn in the clinic, how to talk to people with criminal justice involvement that aren't going to reinforce some of those negative experiences. And then I think the other component of our care delivery model is really the comprehensive health care center, where we have the transitions clinic embedded. It's an FQHC, so we're able to take care of people who don't have health insurance. But there's also a lot of other programs. We're not reinventing the wheel. There's Ryan White funding. There's a support program for people with HIV. We've had a buprenorphine treatment program for more than a decade. There's an opioid overdose and opioid overdose education and naloxone distribution program. We have embedded behavioral health services with 3 social workers and a psychiatrist. So I think building off of all of those resources has also been able to better meet the needs of people with criminal justice involvement.
Thank you, Aaron, and thank you, Shira. This was terrific. It's a fascinating program. I would like to open it now to 2 members of the committee to ask questions, and please put your tent up so I can know that you are asking. Dr. Cooper, you go first.
Thank you so much. This is fascinating. And I had a question. So one thing that we've talked about here is, is it possible to have, buprenorphine and methadone kind of dispensed or prescribed in the same location? And maybe can you integrate, infectious disease care within a methadone program using a harm reduction model? And I wondered, Montefiore has a methadone program, right? Quite a large one. To what extent do you guys work with the methadone program, and has it embraced harm reduction and integration of infectious disease prevention, treatment, care?
Well, I think in particular, the opioid treatment programs in the Montefiore Einstein system are outstanding. There's 3 different wellness centers through the Division of Substance Abuse at Einstein. And one of them just happens to be across the street from our FQHC and across the street from our transitions clinic. So we do have a close relationship with them. And if buprenorphine treatment isn't working well for people, we can refer them across the street and facilitate that process of transfer of care. On their side, they also have primary care integrated into the opioid treatment program. So they're doing a lot of interesting, exciting things about hepatitis C treatment and directly observed therapy and group-based treatment for hepatitis C within the opioid treatment program. I wouldn't call it low threshold, though. I mean, I don't know of any sites that are offering low threshold methadone and then low threshold buprenorphine treatment and primary care or HIV services in the same site. I think just the way that methadone is regulated in the United States, it makes it very, very difficult. Yes, right. But if people are coming to an opioid treatment program every single day to pick up pharmacotherapy, people tend to prefer methadone.
Jody?
Well, this is really excellent work, both in your shop and nationwide. I guess my question's more for Shira about the nationwide. We're charged with looking at integration of addiction treatment services and infectious disease services. So I'm wondering if, these transition clinics across the country, what proportion of them are seeing patients and providing both addiction and integrated infectious disease services, HIV, hepatitis C treatment, and bacterial infections from post-hospital transitions and the like.
That's a great question. It's really the large majority of our sites. That's part of the work that we've been doing, kind of when I talked about the assessment of the sites is, really to be able to support this patient population, really need to be able to have behavioral health integration at the primary care site. So if sites really aren't at that place yet, we try to help support them in that development and then in the development of the program. So for the large majority of sites, we see that we have some difficulties, in our sites that are in states that have not expanded Medicaid. It's much more difficult. So I can't say 100% of our sites do, but the large number, and in California, all of our sites provide medication-assisted treatment and all, treat patients with hepatitis C and HIV, although some of the clinics may have a specialized program for HIV that is, co-located within their primary care clinic. So it is really we see that as being just, a core component of the work.
And also, from Aaron's presentation, one of the many exciting things is the training path for people who come through and go on to really be leaders in the career. Is that happening with other transition clinic programs? Are people going on to do work in correctional health and related fields?
Mm-hmm. Yeah, definitely. And a lot of our sites do have affiliations with training institutions, so they have residents and students, and then they go on to, do work in this field. So that has been a really positive piece of the work nationally as well.
Great. Thank you.
Thank you.
Thanks so much. I really appreciate all the work you're doing. I'm very excited about the involvement of community health workers, and I'm wondering if you can give us even some more details about your work with the Osborne Association and how community health workers are recruited to work on this, as part of this program, the actual training they receive, and then what are some of the, day-to-day tasks that they do. And I've got a second question too, but.
Okay. So our community health worker through the Osborne Association went through a training as part of the Transitions Clinic Network, had a Center for Medicaid and Medicare Innovations Award, where they were able to provide training to community health workers across the country. So I'll let Shira, are you okay talking about the training?
Yeah, absolutely. Is there anything else you want to say first about your community health workers? Or?
Well, I would. Why don't you talk about the training, then I can.
Okay. Yeah. No problem. So, for training community health workers, we kind of see it in two parts. To become a community health worker, there's kind of core competency training. There's a group called C3 that nationally defined what are those core competencies. So, as many of you know, training community health workers, there's no standard certification nationally. Many different organizations train, and those curricula look very different. So there was kind of an effort a few years ago to try to standardize what are the core competencies that community health workers need to be able to be trained. So in our work here, as I mentioned early on, we partnered with City College of San Francisco and added on to their core competency training, some specialty training for the community health workers who have histories of incarceration to specifically work in the health system, helping people with chronic conditions coming home from incarceration. So there's a secondary kind of specialty training. So the way we've trained in the past is partnered with City College to do the core competency training and the specialty training. But as our network has grown and we've kind of encountered some barriers to training nationally that have to do more kind of on the federal side around kind of national training for community health workers, our organization has started to rely on local trainings for core competencies. So working with local community college or other organizations locally that do train in the core competencies. And then our organization does the online training for the specifics in our model of care, which is, working with formerly incarcerated community health workers to work with those individuals specifically.
So the community health worker that we were working with for years, who actually just left Montefiore, sadly, went through that training at City College, and he did all the work online, and it was a 2-year process. But the day-to-day tasks were, so the Osborne staff inside the prisons upstate, they would make referrals to Richard, and we had a standardized form where people would fill out what their needs were, and then when people came home, Richard would meet with them. Or there's a release facility in New York State, the Queensboro Correctional Facility, where he would go into Queensboro Correctional Facility and meet people prior to release. And then he would accompany them to the first visit and help out with paperwork. So I think there's the emotional support, there's the logistical support. And then he had a dedicated cell phone. So if people had questions and they couldn't get through at the clinic, or I think one of the big issues that we run into is self-management skills. And when people have been incarcerated for long periods of time, it really detracts from autonomy. That people get called down for medical visits. People don't have control over their own medications. And I think sometimes just the self-management skills and going to a pharmacy to pick up your medications and things like that have been, it's more of a passive, in jail or prison, it can be more passive. Not everybody's like that. So I think sometimes people would need different levels of help in going to the pharmacy, scheduling follow-up visits. And I think one of the things that's really impressive to me, Emily Wong, our colleague at Yale, did a randomized control trial when she was a resident in San Francisco, where they met people who had chronic health conditions prior to release from prison, and then people were randomized for primary care either at a community health center or at a transitions clinic. And the people who were randomized to the transition clinic received these package of services and were less likely to have hospitalizations or emergency department visits. And we don't know exactly what the mechanism was, why, but my hypothesis is just that cell phone and that connection with a community health worker, that when people had issues, they weren't sure whether to go to the emergency department, or they weren't sure if I need to pick up my medication, I'm running low, so then they end up in the emergency department. My hypothesis is that they just call the community health worker, and they help them to navigate the system in a more efficient way.
And then I'm just can I jump in for a second on that, just before we go to the next question? I just wanted to kind of clarify one piece and then add something. For that study, we weren't actually meeting folks inside the prison. They were all recruited by the community health workers to come into the clinic, and then they were randomized. And it showed a reduction in emergency department utilization. And then we also did see a reduction in ambulatory care sensitive hospitalizations in a subsequent study. So I think those are our key findings. But I think, one of the things in thinking about that work is, we do specifically train the community health workers in helping people avoid using the emergency department. So we have a specific training to teach them, if you get a call from a client and then this is what's going on, to help them direct the patient to the appropriate level of care. And then also kind of adding to some of the other things that the community health workers are doing kind of on the day-to-day basis. The community health workers, I think Erin gave a really great example of how community health workers can go into the system and meet with folks and bring them in. But the reality is that's a real challenge for many of our sites because of major barriers in the criminal justice system, allowing people with histories of incarceration to come into the system. And so, one of the things we've seen in one of our sites in Santa Clara County, where their local county jail was making appointments for people who were coming out of incarceration, only 30% of those people were coming to their appointment. But then when the community health worker would go inside and meet with the client, the show rates went to 70%. So that kind of piece of being able to connect inside is critical, but yet there are still so many barriers to effectively doing that for people with histories of felony convictions. So one of the things, the other piece that the community health workers do, which is critical, is kind of that outreach to find people who have been recently released. And so maybe not connecting with them only inside, but also when they're just very recently released. So anywhere, I mean, it could be homeless encampments, it could be emergency departments, it could be at probation or parole. So there's so many different places our community health workers are looking for these folks because they're not really coming into the clinic on their own so much. A lot of times they have competing priorities. They don't know how to navigate the system. And then once they come in, the community health workers really help with that. As Erin mentioned, the health system navigation. We've had patients who have actually gotten lost in our waiting room because they didn't know to check in because they're so institutionalized. They just come and sit in the waiting room, and then it's not until the end of the day that someone realizes that they never checked in and didn't get seen. So the community health workers, really kind of help them through every aspect of the visit and all the navigation around the social determinants of health. As Erin mentioned, self-management support, mentorship, emotional support, and then also really importantly, and I just want to underscore this without going on too long, is the advocacy component. The community health workers will advocate for the client on an individual basis. So around housing, for instance, if you have a felony conviction, sometimes people will get rejected from housing. They don't know they can appeal. The community health worker will help them appeal and really advocate on behalf of the client or advocate on behalf of them in court, for instance. So that component is really critical to kind of supporting kind of a lot of the barriers or collateral consequences of incarceration that patients face. And then they also look more broadly at policies in the community that might be negatively impacting clients, and they're trained to do some advocacy to partner with other organizations to bring awareness around issues that patients are facing that impact their health. So those are the kind of the other components that I just want to throw in there around the day-to-day for the community health workers.
That is fantastic. Thank you so much. I've got one other quick question about training, and that's with the cultural competency training with the residents and other providers. What does that entail? Are you using an evidence-based program to do that, or what materials are you using for that?
Yeah, that's a great question. Oh, sorry, you go ahead and then I'll jump in. Sorry.
So we have a 7-session case-based curriculum that we developed for the residents, which cover so some of it's cultural competence and things like trauma-informed care. Some of it's specifics, like 20% of our patient population has opioid use disorder, so there's a specific module about treating opioid use disorder in the population. But we came up with it, and the residents rotate through, all of them rotate through Transitions Clinic during their second and third years of residency. So when there's the patient sessions aren't as demanding as a regular primary care session, so we're able to deploy some of the curriculum during those sessions.
And then for our organization in training the clinics around cultural humility, we developed an 11-part series in collaboration with colleagues who are formerly incarcerated, actually Kathy Bodine, who's a professor at Columbia, that are a Train the Trainers series where we train the clinics to utilize these modules to train their staff. We usually do kind of a kickoff when clinics first start, where we come on site and often do like a 4-hour training that addresses some basics around the cultural humility, and then they have this kind of ongoing training that they can do. And the kind of critical, it's that everyone in the clinic is trained, right? So if somebody at the front desk is, has stigma against people who are coming out of incarceration, can be really problematic to the program. So thinking about training more broadly, but the kind of really key for me, I think one of the things that's been really key around cultural competence or humility in this work is that, we have these trainings. I think they're a really good start, but to us, the secret sauce around cultural humility is having the community health workers as part of the primary care team. And so we work with our sites to embed the community health workers as part of the team as much as possible, and to really utilize them in a day-to-day fashion around issues that come up around, misinterpretation of what patients are experiencing. So we often will bring the community health worker into the room with us when we're seeing patients if necessary. I mentioned the advocacy. The community health workers advocate to us as providers and staff all the time to say, hey, I don't think you really understood, what's going on with this client. I mean, you can imagine a really busy clinic where, your patient shows up late, you have 5 patients waiting, and, your tendency might be to say, like, oh, just have them come back, and the community health worker can advocate and say, actually this person had a panic attack on the bus, and they really, need some support and some medications, and when you hear that story and they advocate for them, you say, of course, I'll see this person, I'll make it work. So, I think on the day-to-day basis, I've been doing this work a really long time. I still rely heavily on my community health workers to make sure that I understand what's going on with the clients. And so a lot of our work is really training the teams how to value the community health workers, how to best support the community health workers and really integrate them into the teams. Because if you don't create a system that supports them and really values their voice and what they bring to the table, you're really losing a lot of what, the community health workers do. And what a really big part of what they do is helping kind of translate or be cultural interpreters across systems for the patient. So to me, that's actually the most effective intervention we have around cultural humility in our work.
Okay, so Sandy, you're next. I just want to remind the committee that we got 10 minutes left.
Oh, well, thank you, guys. This is Sandy. I can see you. Huh. No, thank you so much. I just had a couple of questions. Since, as you know, we're charged with identifying programs that are integrating infectious disease with opiate use disorder treatment. It's really difficult to find, criminal justice-based programs that are doing that. How many of the 29 programs are actually doing HIV, hepatitis C testing and treatment with opiate use disorder treatment? Are all 29 doing that?
Not all 29, because as I mentioned, in some of our states that haven't expanded Medicaid, it's really challenging to sometimes provide treatment, particularly for hepatitis C or opiate use disorder for the patients. But the large number of our programs do, and in California, really all of them. So, I think it's really, some of what we see is really related to, funding.
Right. Thank you, because that's my next couple of questions, which was, so I was going to say how many of your programs are in Medicaid expansion states and which ones are, and you just answered that the ones, well, you didn't answer that, but the next question was going to be of those, how many were doing integrated treatment? So you're saying that in the non-Medicaid expansion states, you're unable to do the integrated treatment.
Less so. I mean, one of our programs in Texas does HIV and substance use treatment based out of Dallas, so they are doing that work. But in North Carolina, for instance, we found it to be much more difficult, although there's a lot of things happening in the state around opiate use disorder and treatment. So there's been more and more support in that state. So it varies, yeah.
So I was reading in the program abstract that was written that one of the barriers is that there's no sustainable reimbursement mechanism for the high level of care, and the Bronx Transition Clinic as a barrier for providers to patients for these services, and resources and providers are not readily available to provide comprehensive mental health care, which is a similar barrier that we're seeing, right, that we're hearing among all the other programs. So if we have a charge in this country to end AIDS and end HIV, and yet we're seeing new epidemics occurring in people who are using drugs, what do you think, what are your thoughts, both of you, about a dedicated program like a Ryan White Care program that would be provided to states to be able to access not just treatment for opioid use disorder, but provide like what Ryan White Care does for our patients living with HIV and the other services that we're seeing that they need? including housing and assistance with housing, et cetera.
Yeah, I mean, absolutely. I think that Ryan White model of care delivery would be ideal for what we're trying to do and would allow for support of all the different services. And thinking about, also you mentioned housing, and that is one of the things that our patients struggle with the most. And especially when it comes to opioid use disorder treatment, if people are living in shelters or living in housing where they're going to a shared bathroom and there's syringes in the toilet, it's exceptionally difficult to remain abstinent from opioids. While there are mechanisms in New York City to provide housing for people with HIV, for people without HIV, there aren't the same resources for housing. So I think it not only has to be comprehensive medical services, but comprehensive care for people's lives.
Thank you.
Thank you. This is Ellen Eaton from UAB. One of the consistent themes we've heard today and also yesterday was this integration of the electronic medical record. And I'm curious what currently happens in terms of transitions between criminal justice settings into the community in terms of transition of information. What's the current status quo and what you think is feasible within the limitations of policies on confidential, patient PHI, essentially, between those two settings?
Yeah, I mean, I think from the state prison system, getting medical records is very difficult, but I think there's a lot of risk if people, because of the stigma of criminal justice involvement, people may not want their healthcare providers to know that they just came home from jail or prison. So I think within the Transitions Clinic Network, we've had these debates about whether integration of an electronic medical record would be, the positives of facilitating access to information, whether that would outweigh the risks of disclosure of people's criminal justice involvement without against their will. Shira, do you?
Yeah, I mean, I agree with that. And, I think the state is kind of across the country is just abysmal as far as there's being very little access to records in a timely manner for providing care for the patients. There's a lot of room for improvement. But I certainly agree that there needs to be, a lot of caution and, ensuring we're not creating something that is further stigmatizing people. I think when I think about it, is there a way to create, and I'm not an IT person, but is there a way to create a system where the patients have more control of their own information, where they hold the information and they can share it with who they choose? I think one of the things that's really challenging with the patients that we serve is, they're coming from the criminal justice system. They're given a number. They're, don't have autonomy. They have no confidentiality, and they're just kind of shuffled around, really kind of as humans with no rights. And so that kind of attitude sometimes persists inadvertently or advertently, depending on, who we're talking about, as far as, continuing to control and treat people in that manner when they come back to the community. But if we really want engagement and we want people to use services, as we all know who treat these patients, you really have to treat people as human beings and really respect their autonomy and their decisions and meet them where they're at. And so, is there a way to create a system of shared information that maybe the patients have more control over that information?
And does the community health worker at all have a role in that transfer of information in your current protocol? Do they ever help relay information from one setting to the next? I don't know if that's...
sometimes they'll help, have patients sign releases of information before they come to the clinic so we could get the process going, to have that information. But they're not really that involved in relaying kind of health information, and that's always a challenge that they face because they're interfacing a lot with probation and parole, so they really need to kind of keep, they can take in information, but they have to make sure they're not passing it back. So, they're not kind of formally, in part of that system now.
Thank you.
Thank you so much for this presentation. You seem to have had a tremendous impact on your patient population. How has that impacted the staff? Is there a reciprocal response in terms of staff retention and morale in seeing your success?
Well, so I think we, as part of, as we said, part of the training for the clinic and preparing the clinic to do the work is to involve the entire staff in in that preparation. So I think we've had in services over the years several times, and really the staff is proud of the work. A lot of the staff comes from, we're in the South Bronx. It's a heavily policed community. It's been disproportionately affected by the criminal justice system. And 50% of our patients in past surveys have reported that they had a family member who had been arrested or in jail or prison. Staff members come from the same community, and they're glad that we're doing something about it. They want to know about it. And I think anytime you're in an FQHC, there's turnover of staff, but I don't think it's specifically because of this program. And again, there is a lot of pride in the fact that we have a program for people with criminal justice involvement. I mean, at the clinic, we also have a program for people who recently immigrated to the United States, and people are proud of that clinic as well. I think that connection to the community is important.
Yeah, I'll ask a question and try to be quick. You wrote a sentence in your report that said that there's no sustainable mechanism for the high level of care that you provide. How, within an FQHC, what measures have been effective to sustain care, elements of care? Or if you don't want to answer it that way, how would you fix that problem so that, and this may just get to what Sandy asked already, so that's why I put my tent down, but that was my specific question.
Yeah, I mean, I guess maybe.
You want me to answer this?
Yeah, you could.
Yeah, I mean, I'll just jump in just only because we see kind of every possible way of funding this program. And so I think one of the things I'll say is there is no direct mechanism. So what sites are doing is just sort of this wiggle of trying to utilize different programs or funding sources that may pay for this. So we see a huge range across the country. Things like what's been most effective in California, though, are related to kind of more value-based payment systems. And in California, things like the health homes work, or our whole person care pilot, which is under the 1115 waiver, which allowed for the state to have counties be able to pay for services that are not normally covered by Medicaid, like connecting systems. So we're working with LA County, for instance, which is hiring 128 community health workers with histories of incarceration and embedding them throughout the community and in primary care settings. So that is using Medicaid dollars, but would not have been possible previously without the 1115 waiver. Some of the other things we see sites doing are things like leveraging criminal justice dollars. And so when we see reforms happening, they're oftentimes utilizing those dollars, reusing them in more healthcare settings, kind of as there's more awareness that, people impacted by the criminal justice system may need treatment and not incarceration. Some sites are able to just kind of, are dedicated and passionate and are able to use some of their funds that they're making, as an FQHC to pay for these services. Other things we've seen that have been effective is the Medicaid managed care organization. So in California in particular, we've had a few Medicaid managed care entities step up and just pay for these community health workers because they do believe that they're getting a return on investment. And so particularly the Medicaid managed care plans where they're the only plan in the county so that they know that these are all their patients. There's no question that people coming home to that county are their patients. So those are some of kind of the main things that we've been seeing that have been a little bit more promising rather than just a lot of the grant funding that has oftentimes started these programs and sustained them over time.
Yeah, that's what we've shifted from grants to now we're trying to establish a close relationship with our Medicaid health home to provide the care coordination and outreach services.
And that's an accountable care situation, so if you save money on hospitalizations, you can justify the community health worker's salary that way. Is that true, or am I not right?
Well, I mean, within the Medicaid health home, there's a per person monthly fee that,
Right.
that the organization can collect to provide the outreach services.
Okay,
I mean,
well,
there's challenges with that. Like for our help homes, it's people with chronic conditions, and you have to meet certain criteria. So it will cover some people who are coming home from incarceration, but not others. So there still is yet to be, a dedicated program specifically for this population that doesn't sort of require the sites to kind of maneuver. And then lastly, I'll just say a lot of health departments are starting to see incarceration as a public health issue. And we have seen many departments of public health around the country fund these programs as well.
well, thank you very much. I want to thank you for your participation and for giving us your information. Our time is up, so we will move on to the next group of speakers. But again, thanks for taking the time, for giving us the information, and we will obviously consider all these things as we think going forward what our report is going to say.
Can I take 10 seconds?
Sure.
One thing that didn't come up yet, policy-wise, a lot of the other people commented on policy, is the Medicaid inmate exclusion policy, which Jody Rich knows a lot about, and I think it's part of the report, the way that influences access to care during incarceration, and then the transition post-release is really important.
That's very useful. Thank you.
You're welcome.
Okay, so.
Thank you.